Welcome back to this training session for emergency operative neurosurgery. In this session, we'll discuss regarding how do you operate upon a patient with frontal and temporal contusions. What is a contusion? Contusion is bleeding within the brain parenchyma. Contusion is bleeding which is intermixed with some normal brain parenchyma. So contusions are usually almost always because of head injury. That is, they are components of traumatic brain injury. So let us know how to operate upon these serious conditions of the brain. Okay, and let me share my screen. So we'll be discussing surgery for several contusions of the frontal and temporal bones. And also I will speak about the lobar resection in case of a temporal contusion. So before I go into the operative procedure per se, let us discuss regarding the indications for surgical intervention in these cases. An operative intervention is indicated in the setting of the frontal or a temporal contusion which is greater than 20 centimeter cube in volume, which is more than 20 cubic centimeters in volume, and which is also associated with one of the following: Glasgow coma scale of 6 to 8, midline shift of at least 5 mm, and cisternal compression. Any lesion, irrespective of location, which is greater than 50 cubic centimeter also requires surgery. And also any lesion, irrespective of size, which is causing progressive neurological decline, which is causing refractory intracranial hypertension, which is defined as ICP more than 20 millimeters of mercury, which is not responsive to maximal medical therapy, or when you see mass effect on a CT scan. And also a temporal lobe hematoma greater than 30 cc in volume with or without any midline shift or elevation of the middle cerebral artery. These patients are particularly prone for transtentorial herniation because the space of the middle cranial fossa is very limited. So these are all the classical indications for a patient with frontal or temporal contusion who requires surgery. So this is a patient with frontal contusion. Obviously, this volume appears to be more than 30 cc in volume. You can see the midline shift. You can see the ipsilateral cortical sulci being obliterated. Similarly, this is a patient with temporal contusion. The volume is more than 20 cc. Again, the Sylvan fissure is obliterated. You can see the ventricles, they are compressed, they are not seen. Obviously, the intracranial pressure is very high in both these patients. One important decision which you have to take is the choice of surgical approach. Two different approaches are described. One is a bicoronal and the modified pterional approach. For frontal lobe contusion, which are medially located, frontal contusions, a bicoronal approach is more appropriate. But for a contusion which is located lateral in the frontal lobe, or when the frontal contusion is associated with a temporal lobe, or when the patient has a temporal contusion alone, then modified pterional approach is preferred. In this episode, we will speak about pterional approach, modified pterional approach. In my next session, I will be speaking about bifrontal approach. So, as everything, as any operative neurosurgical procedure, positioning makes an important part of the procedure. So you can see the position over here. This position is almost similar to the position which we keep for either for decompressive craniectomy or for evacuation of an acute subdural hematoma. So I'm not speaking much about this particular step. You can refer to our previous videos on decompressive craniectomy, our previous videos on evacuation of an acute subdural hematoma. It's nearly same as that. Even the skin flap for a modified pterional is nearly same as a classical falconer flap, which you take for decompressive craniectomy. But depending on incision, you can taper the extent of the posterior extent of the flap. If it's a frontal, if it's a lateral frontal contusion, the flap needn't be so large. You can tailor the posterior extent of the flap. But when you are deciding the extent of flap, you should take into consideration the location and volume of the frontal contusion. And also you should take into consideration the location of the edema around the contusion. The flap which you are taking into consideration, the flap which you are planning should take into consideration the combined volume of the contusion along with the pericontusional edema. It should encompass both of them. Elevation of the temporalis muscle, similar as the decompressive craniectomy. The bone removal, which is almost similar as evacuation of a decompressive craniectomy or evacuation of acute subdural hematoma. The bone flap removal, almost same as the previous procedures. Opening of the dura mater, almost same. Now once you have opened up the dura mater, now comes the temporal contusion into view. So what are the steps for evacuation of the temporal contusion? First, identify the Sylvan fissure. So step 1 is identify Sylvan fissure. So how do you identify the Sylvan fissure? Identification of the Sylvan fissure is best done in relation to the location of the sphenoid ridge. So this is the sphenoid ridge. If necessary, you may drill the base of the sphenoid ridge until flush with the anterior middle cranial fossa to augment the surgical exposure. Then inspect the cortical surface. Second step, inspect the cortical surface. Identify the ideal area of entry. An area of obvious contusion or cortical disruption is the ideal site of entry. Once you have identified the site of entry, so second step was identify the site of entry. Once you have identified the site of entry, cauterize the superficial vessels and the pia mater at the planned entry site. Use a number level blade or 15 blade. Approach the hematoma cavity in the subpial plane with a combination of gentle suction and bipolar electrocautery. Once you enter into the hematoma cavity, use a gentle suction to evacuate any liquid clot and also the solid clot in a piecemeal fashion. Continue evacuation until you see the gliotic brain or the normal brain or the edematous brain. Now, what are the important pearls or important hints in this phase? You can identify the Sylvan fissure either with the help of a sphenoid ridge or with the help of the middle cerebral vein. But of both the landmarks, sphenoid ridge is a more reliable landmark. When you are entering into the cortical cavity, you can use a malleable retractor which is supported by cotton patty which is moistened with saline. So you can use your malleable retractor over this cotton patty gently. So this helps in retraction. It helps in illumination going into the cavity. At the same time, protects the underlying brain. And one more important, this part of the surgery, that is evacuation of the hematoma, is always done, is always at the best done. In our institute, it's always done with the help of a operating microscope. Coming to the next step. Some cases where the temporal contusion is very large. In the event that the temporal lobe is severely contused, you may plan for an anterior temporal lobectomy. When you are operating on the non-dominant temporal lobe, that is on the right side, usually, we can remove up to 5 to 6 centimeter of the temporal lobe. If it is on the non-dominant side, that is on the left side, try to remove the less amount, which is less than 3 to 4 centimeter. In any cases, usually the posterior limit is the junction of the Sylvan fissure and the central sulcus. But these are just guiding points, but not always. And depending on the extent of contusion, extent of permanent damage to the brain, extent of edema, the operating surgeon can take a decision up to the extent of temporal lobectomy. So once this is done, ensure perfect hemostasis. Use a combination of Surgicel, combination of Abgel. Sometimes you can use pressure from cotton patty. Ensure complete hemostasis. Once you have done with complete hemostasis, plan, just like you plan for the evacuation of acute subdural hematoma, assess what is the extent of edema in the brain. Assess whether the brain is below the surface of inner table of the skull or above that. If you feel there is no edema, if you feel that the chances of developing an edema in the future date is less, you can do a primary closure of the dura. Suppose the brain is bulging. Suppose it's bulging above the level of inner table. Suppose either the radiological picture or the appearance of the brain suggests that the patient is going to develop edema in the future days. You can do an expansile duroplasty. Some of the surgeons in my place, they prefer not to do a watertight duroplasty, but they close the dura with tack-up sutures and then augment the duroplasty with Abgel. In our experience, it's a beautiful technique. When we open up the brain for bone flap replacement, we usually see a perfect layer which is formed over it. Similarly, just like the previous sessions, the session of decompressive craniectomy, the session of acute subdural hematoma, you can decide whether to remove the bone flap or replace it back. Then you close the temporalis muscle and the skin in layers after placing a closed suction drain. So this completes my session on operative session on evacuation of frontal and temporal contusions, with the approach being a modified T-Renal approach. In my next session, we will discuss the bifrontal approach for medial frontal contusions. So let us complete our session over here. Thanks for attending this session. Thanks for subscribing to my channel. Do share these videos with your neurosurgery colleagues, your junior colleagues. This will be definitely useful. And as we all know, these emergency neurosurgical techniques are life-saving. And when done meticulously, this can, although there's still a high mortality depending on the presenting disease of the patient, this technique is life-saving and it can save lives of hundreds of people in our career. So bye for now. Thank you. Let's meet again in our next session for bifrontal decompressive craniectomy for medial frontal contusions. Thank you.